So that brings us to today. We have the talk, The Care of the Patient in the Hospital, Recollections at Chestnut Lodge, with Dr. Christopher Keats. Dr. Keats, after psychiatric residency at the University of Rochester, began work at Chestnut Lodge and completed analytic training at the Washington Psychoanalytic Institute. When Dr. Keats arrived at Chestnut Lodge, Harold Searles was no longer a therapist there, but he was doing consultation for many of the workers there. Dr. Keats served as a therapist, unit administrator, and later director of the psychotherapy at the lodge. He also has had a private practice in psychiatry and psychoanalysis, and continues that practice in his office in Bellevue since he moved here to Seattle in 2014. He's currently on the faculty at SIPSI, and where he's a consulting analyst, and he's also a full member of MPSI. So with that, one quick thing, we'll take a break, about an hour in, 10-minute break. With that, I'm going to hand it over to Dr. Keats.
Thanks very much. If people can't hear me, please tell me, and I'll try to speak louder. Is that all right? Can you hear in the back? So, I'm very glad to have an opportunity to remember something about the lodge. When I don't remember exactly, was it Chris maybe who was the one who invited me to do this? I can't remember, but when we talked about it, we talked about me not reading a paper. And I'm very glad not to read a paper, but it also leaves me kind of dizzy in terms of the possibilities. I could say any number of things, but I think I'm just going to go ahead and start. And I'm very open to hearing questions from you as we go along. So please feel free to interrupt me with questions. And also I want to introduce my wife Denise, who I met in bed at the lodge.
Wow.
I was administrator at that time. I was administrator for a unit, and she was a therapist, and she was arguing with me about the patient not needing medication. She felt the patient didn't need medicines, and I was of the opinion that the patient would do really a lot better with lithium. And we went to finally I persuaded her that we should do this, and we went to see the patient together to tell the patient that it was going to be lithium or the highway. So the patient didn't want to listen to this. She had put her radio up on high, so high that neither one of us could hear ourselves think. And Denise dove across the bed and pulled the plug out of the radio. And the patient started to grapple with Denise, and then I climbed on it. But Denise knows a lot about the lodge too, and I hope she will contribute as we go along, because she worked there even before I did as the director of nursing, before she became a psychologist, and then came back to the lodge later.
You forgot to mention how what's her name put us on the internet.
Oh,
That's totally crazy people.
If you Google me, I don't know how many layers you have to go in to find that I'm totally berserk, because this woman has put up with posts saying and that Denise is just as crazy as I am.
The lithium patient?
The lithium. The lithium didn't help her enough.
She remembered us, the transplants.
That's funny.
So, as Colin said, I started out at the University of Rochester, and at the University of Rochester, I had gone there because I heard that it was a very biological residency, and I was interested to learn as much as I could about biological psychiatry. And, it's a political call. It says political call. That's the end of that. So, I didn't realize it, but University of Rochester had a psychiatric department which was run by a guy named John Romano, who was a world-class genius. I had no inkling of this. And he had known Madame Curie. I mean, he was just a person who had all sorts of interests. And when he built the University of Rochester psychiatric section, it was actually larger than the entire rest of the Strong Memorial Hospital. It was called the R Wing, after Helen Woodward Revis, who was a Jello heiress, and apparently there was somebody in the Jello family who had mental illness, and she donated a lot of money to this effort. So I landed in a place I had never even dreamed I would come to, which was just full of academic excellence. There was George Engel was there, who started the idea of psychosocial psychiatry, biopsychosocial, I think was his term, and John Romano, and a number of analysts. Romano had brought in psychoanalysts, and there was a training analyst, and there were a number of other analysts, and they seemed to have, as I was learning psychiatry, and Denise told me on my way down here that I talk too much, and I'm sorry, I'm going to ramble a little bit, but if I get off topic too far, please rein me back in. When I started in psychiatry, I had zero idea what psychiatry was really all about. And as an example, I came onto the unit as a new resident and found them in a group meeting discussing saying goodbye to the psychologist who was going to move from our floor down one floor below. And we spent the entire meeting saying goodbye to this guy. He was going to be on the floor below. I had no idea why they were spending so much time talking about, saying goodbye. But eventually I began to pick up a little bit about this, and I thought that the analyst had the best way of thinking about the patients and the best way of listening to them. So one of the chief residents gave me this book, The Collected Papers on Schizophrenia by Searles, and I found that fascinating. And then I had a patient who never talked to me, and the chief resident said, well, there was an interview between him and Searles. Searles used to go around from one place to the other and interview patients. And he had a taped interview, like these tapings here that Chris is doing, of my patient talking with Searles. So I got this out of the archive and looked it up. And sure enough, there was Searles with my patient, and in those days, instead of having something like this, you had to wrap a little wire around the patient's neck. And he wrapped a little wire around the patient's neck so they could be videotaped. And then he pulled the patient over like this and sat him down in the chair like that. And then he sat down, and the two of them glowered at each other. And Searles said, so, he said, you wanted to put my eyes out? And the patient said, yeah! And they talked for the entire session. And he never said a word to me the entire time I had seen him. So I thought this was kind of magical. I didn't know how he had done that. And I thought I'd be happy to go to the place where Searles worked to see if I could learn it. Mm-hmm. Yeah. And many people tried to dissuade me, John Romano being one of them. He said that nobody has ever shown that anything helps a schizophrenic patient other than giving them medication, correcting their delusional material when it comes up, and getting them a job so they have better self-esteem. Those three things are the only things that help a schizophrenic patient. And if you go to Chestnut Lodge, you're going to go to a place which is kind of atavistic. I went anyway.
When was this? Chris?
Yeah, when was
1978. So I went anyway, and when I got there, I was brought back from 1978 into 1950 or something. The place was on 100 acres in Rockville, Maryland. As Colin said, it had been a sanitarium back in the old days. I think that was a place where people would go mainly to get over alcoholism. And it had been transformed into a world-class psychoanalytic hospital. And I'll get to what I mean by psychoanalytic in a minute. By Dexter Bullard Sr., who was the son of Luther Bullard, this person that Colin mentioned, who had been the original owner. And the hospital was still owned by the family, still owned by Dexter Bullard Sr., and his son, Dexter Bullard Jr., had been brought in by Dexter Bullard Sr. to take over the hospital. So his son had been at the residency and then psychoanalytic training in Boston, and he was fully ready to roll as the head of the hospital. But Dexter Bullard Sr. had brought together lots of people from, and one of his skill sets was that he was able to tolerate a lot of diverse opinions. So he had people like Harry Stack Sullivan coming to give consultation. He had Frieda from Reichman as a staff member, and he brought in lots of other people from the National Institute of Mental Health who had training there, and people who had idiosyncratic approaches, and they all argued together. So nobody had a monolithic approach to how to do the treatment, and instead there was a kind of a Tower of Babel with everybody speaking different tongues. And what Dexter Bullard Sr. did was to tolerate that and to have everybody on, in this mix. So, as I said, the hospital was on 100 acres, and when you came there were no signs. Nobody knew that this was a psychoanalytic hospital from the community, except, I guess, probably people who were next door neighbors knew it. But there was no sign. There were no fences. It just was rolling acreage, just rolling acreage, and lots of little buildings. I mean, if you go to a place like I did later on, I went to Westchester, I think, where Kernberg worked, which was all very orderly buildings with little, it was uniform and orderly, but the lodge was not uniform and orderly. It reminded me a little bit of Lookout Mountain in Tennessee. There's a sort of a garden gnome aspect of it. You could see the grounds were full of things like garden gnomes, although I don't think there were any garden gnomes. The little road on which you would travel to go from one unit to another in the hospital was lined with white rocks because Dexter Bullard Jr.'s wife didn't like the fact that the doctors would often drive off the road onto the side to get around each other, so she had the little white rocks there. And they were big white rocks, so you couldn't drive off the road because you hit the white rocks. But it was a totally homegrown idea. It wasn't, and I used to use the white rocks. I had a Datsun 210, which had terrible traction. And I used to get the white rocks and stick them in the trunk of my car so I would be able to drive them. And there were chestnut trees, which lined the road also. There were 5 psychoanalytic units, or psychiatric units, 3 in what was called the main building, which is this building that Colin was talking about, that was the first hotel. And the first floor of that building was administration, and the next 3 floors were units, psychoanalytic units. And then there was a big house called Hilltop, which was set at some distance, and then there were 2 other adult units, Little Lodge and Upper Cottage. In the days when I first got there, you would go, if you were a locked up patient from one of the units in the main building, if you got better, you would go to Little Lodge. And I remember hearing on the payphone a woman talking the first day I got there, saying to her mom and dad, "Hey, Mom and Dad, I just got to Little Lodge," which was a big step up in terms of stepping down, so to speak. In addition to that, there were 4 houses which were in a kind of a semicircle, which housed adolescents. Dexter Bullard Jr. was very interested in having the hospital move out of just doing adult work to also serving adolescents, and he brought Margaret Mahler. I think Margaret Mahler came to speak at a symposium before I got there. But he kicked it off with a heavy hitter speakers and tried to have then people of ages. I think, what was the youngest age? 5?
The what?
The youngest that was ever in the hospital.
I'd say maybe 12.
12, so it wasn't 5. So we had patients from 12 to 90. And the people in the adolescent cottages went to school at the hospital, and each of the cottages was run by a kind of mom and dad arrangement. They would stay with the patients, and the patients in those houses, maybe there were 10. Or
A few, maybe 8.
8.
Yeah.
So there were 8 child patients, 2 house parents, and then they would all go to school. And there were also groups at the little houses, which were run by people like Denise. Denise had a group. It's actually written up in a book.
It was an adolescent group at the school.
Adolescent group at the school.
Yeah.
So I learned when I first came that I would have 6 patients. But I wouldn't have them all at once because I would be getting my feet on the ground. So for the first 2 or 3 months, I had maybe 1 patient. And I was to see the patient 4 times a week. And I was to have a supervisor. And I was to have an office. I was given an office and a little couch in it. And I had 2 secretaries who took dictation if I wanted to dictate something. And downstairs there was a library which was lined, it was maybe twice the size of this room, lined with books. And a little coffee machine, actually not a machine, but coffee dispenser. And this was a place where conferences were held around patient care. And it was enormously helpful to all of us to have a place where all these books were located and where the coffee was located, where in between patients you could go down and get coffee and look through the books. I don't know if everybody's been to the library recently, but most of the time you have to look up something and then you get it. But you don't have, well, like many libraries now, you don't have the capacity to browse everything. So if you were looking for a book and you found one, right next to it might be something which was even more interesting. And that kind of thing is, we're losing it now, but we had it there at the lodge. So I was also anxious because I had come from my graduate psychiatric residency, and I thought, how is it possible for me to be helpful to these severely ill patients who are paying upward of, I don't know, it was at that time $60,000 a year, which was obviously simply a pittance now, but it was a lot of money in 1978 to come there. These were people who had failed at treatments every place else and finally came to the lodge. And why was it going to be possible for me to help them? I was very anxious about that. I had zero idea how I was supposed to do that. And I was told by one of my supervisors that I wouldn't be able to do it for 5 years because I would have to get better. But that in the meantime, my enthusiasm, if I had any, would carry the day. So, so I had to become enthusiastic. I was also frightened because the patients were severely ill, and I thought I was going to get killed or something. And the then director of psychotherapy was a guy, Ping Ni Tao, who had English as a second language, and who said to me, without me saying anything to him, I came into his office and sat down to be supervised or to be introduced to him. And he said to me, without even saying hello to me, he said, "I only been hit once." As if he knew what I was thinking about. And he said, I was watering plant. And patient came in, and I continued to water plant. And that's all he said about it. So later, just to say something more about Peng Tao, he ran a group of a kind of a group supervision for us, and he never said anything. And I asked Peng after a while, I said, "Hey, well, you never say anything." And he said, "I assume you're doing best you can." And then finally, he died of cancer. I think he had colon cancer, and
Yeah.
he had always written. We had to write notes every month on our patients, and the notes would get circulated amongst the senior staff. So the Pinckney Powell and the owner of the hospital and the clinical director would read our notes, and they would sometimes say something in the margins of the notes. But Pinckney Powell never said anything in the margins. He would just initial them. And when he went in for his operation, where he was going to be seen again for liver metastases, I think he knew he was going to die, and he wrote on the note that came back to me. He wrote a note. He said, "I think you should say this to the patient," and then he wrote something which was totally illegible. So I think he was
Chris,
saying,
Chris, you
yes.
got to add when the patient said to him, "Are you a?"
Oh yeah.
This is a great story.
Patient said that Ping was not saying much to the patient, I guess, and patient says to Ping, "Are you a man or a mouse?" And Ping says, "I am mouse." So I understand lately they can drive cars. I mean, or rats driving cars. So it was a loss to lose Ping, but and he wrote a book which I don't know if everybody's read, Schizophrenic Disorders. It's a psychoanalytic book about schizophrenia. It's actually really good. It covers a lot of work. And it has a nice foreword in it by, I think, by Rusty Bullard, who was the son of the owner, who covered a lot of wartime events. So if you have a chance, it's worth picking up. Schizophrenic Disorders by Ping.
How do you spell the name?
Ping is P-I-N-G.
P-I-N-G, okay, thank you.
And Niepao is N-I-E-P-A-O. And this International Universities Press. So it helped me to hear that from Ping, that he only was hit once, and that if the idea behind that was if I would just turn around and pay attention to the patient, maybe I wouldn't get hit, which I think is good advice. So I think I want to say something about the patient care, because I think the title of my talk today is "What Can Be Done for the Patient at the Hospital." And I don't know how many psychiatric hospitals you all have worked at. I mean, I don't know. It seems like there's a line from Fellowship of the Ring where Bilbo Baggins is saying to the assembled group at his birthday party, he said, I don't know half of you half as much. I don't know half of you half as well as I should like, and I like less than half of you half as well as you deserve. I don't know you all that well, but I assume some of you have worked at mental hospitals, and I don't know what type of hospitals they were. But this place was unlike any place that I've done. I've only done it Strong. Strong was up to date. They had rolling carts that you would roll around through the corridors, which had all kinds of medicines on them. They had everybody was wearing a white coat. It was up to date. And Romano, who was this genius, had actually gone around the country to find out what kind of hospital unit would be best for psychiatric patients. And I don't know where he pioneered it, but they had men and women living together on the same units, and they had a nice little dining room area there for the patients, and the nurses were behind an area with glass, and they could see what was going on. Well, at the lodge, the nursing staff didn't have any space at all. They just were right there with the patients. And there was no little cart. In fact, if you came to the hospital, you'd think the place was kind of shabby. It was like a house. There was no little carts and no spaces for little carts. And they would run into trouble with the Joint Commission for Accreditation of Hospitals, which wanted them to have corridors big enough to push beds through. And of course, nobody was in bed. They were all, maybe they had beds, but they weren't in bed. They were up and walking around. So it made no sense what the Joint Commission wanted. But in order to be accredited, the hospital had to follow, so they ended up having to spend money on things like that. But, so if you first came to the hospital, you would be greeted by the director of admissions and seen by them, and then you would be taken over to your unit and you would be introduced to your nursing staff and to your administrative psychiatrist. And there was an administrative therapist split, meaning that everybody, all the patients had an administrative psychiatrist and they had a therapist. And in the days when I first got there, all the therapists were ND psychoanalysts. Dr. Bullard felt that everybody should be in their own treatment, and he felt that it would be good for them to have analytic training, and he paid for the first 4 years of psychoanalytic training either at the Baltimore Psychoanalytic Institute or at the Washington Psychoanalytic Institute, which were the two institutes at that time in D.C. So the didactic training was paid for by the hospital, which otherwise had notoriously low salaries. It was sort of like working at maybe educational place, academic place, but they don't pay anything. You just work it. But of course, there were benefits in the sense that you got the first 4 years of your analytic training paid for, and you had an office that you didn't have to pay for, and staff that supported you. So, yes.
That's a quick question.
Yeah.
When you came there, was it still common for people to, practitioners to live there? I know at some points practitioners just lived there on campus.
Yeah, well, Frida from Reichman had lived there. Dexter Bullard Sr. had built a house for her to keep her from moving somewhere else.
Oh, so that was unique. That wasn't, most doctors didn't live there.
No, but I think he felt that she would go somewhere else if he didn't.
So he was like,
He set it up.
Okay.
And of course, Dexter Bullard Jr., who then ran the hospital when I was there, had lived there as a child and played tennis with the patients, and they were all involved. And Senior Bullard still lived on the campus at the time when I got there, not Dexter Bullard Jr. I'm sorry if this gets confusing, but Dexter Bullard Sr. had a house on the campus. So they still lived there. They had moved from one place, which was Upper Cottage, or I think it was Little Lodge. They moved from Little Lodge into this bigger house, which was, beautiful rosewood floors, and it was nice. And a little deer on the lawn, tennis courts, and they lived there. And in the middle of the day, on a snowy day, Dexter Bullard Jr., who now was running the hospital, would leave his office and go across the lawn and wipe the snow off the boxwood bushes. So that's different, right? I mean, you wouldn't have seen Herberg doing that at Westchester. This is the family aspect. And I don't know how much of that contributed to patient care, but I think something of it does. Everything is sort of like here. Look at this room. I mean, it's like the place was like this room. It was comfortable and a little seated. But there was a time and motion study that came through to look at how the lodge was doing, and the guy ended up saying, I don't think I would change anything because the patients don't feel outclassed by this. You know, they come and they feel kind of comfortable. They're not doing well, and they see the place isn't doing well, and then they don't feel like they're out of their depth. So then you would get the administrative psychiatrist, you would have your nursing staff, you would be under unit, and then you would be taken, at first you would be taken rather than allowed to walk, 4 times a week to see your doctor. And then taken back to the, by the staff. And that, at the time when I first arrived in 1978, that was the day for the patients. It didn't make much difference what they did the rest of the day. The idea was to bring them to treatment and take them home from treatment, and that was sort of the program.
And nothing was locked.
Yes, the units were locked.
Okay.
If you look, for example, at Austin Riggs, which is a sister institute in many ways, one big difference between the lodge and Austin Riggs is that the units were locked and capable of being locked. When I was an administrator, we tried an experiment of unlocked unit for a little while to see what that would be like. And of course, it worked remarkably well. Because actually people don't need to be locked up as much as we think. But these experiments would always be ended by some bad thing happening, and then you have to lock the doors again. But we had the capacity to lock our units, which was different from Riggs, which did not. Riggs doesn't take anybody that needs to be locked up, they think, and then when they need to be, they send them to Rockville retreat, I believe. So they don't manage it. And for the most part, we could take anybody. I remember saliently a case that was on my unit, a guy who was unpredictably assaulted, and he would get privileges to go out on the grounds with staff, and then out of the blue he would assault them. And after this happened enough times, he wore out his welcome with the staff, which began to feel as if, what were they going to do here? So they sent him to a place near Tampa Bay, Florida, where we had a sister institute, Anclote Manor, which was willing to accept him and transfer. And one time I was at a conference in Tampa, and I went over to see him in follow-up, and looked in on him in Anclote Manor, where they had actually the kind of units where the beds were out like this, and the nursing station was right here, and everybody could see all. And I went in to see my former patient, and I got some good recommendations for Greek restaurants in Tarpon Springs, because the same thing had happened there to him. He'd gone out into the community, and then he would be unpredictably assaulted and end up having to come back. So I only mention him because of the good restaurants in Tarpon Springs, but also because of the unchanging nature of his pathology and the difficulty in treating that kind of person. It was really tough. And how we ended up, I don't think the Bullards would have liked fire setters. I think they had trouble with that also. So there were a few kinds of patients that weren't manageable. Denise reminded me as we were driving in that when I first got to the hospital, and certainly when she was there as nursing director, there were big changes going on in the sense that there was a move now towards using some medications. I mean, patients would be admitted and then taken off of all their medicines for the first maybe 3 months to see where they stood, to get a kind of a diagnostic sense. And when I say 3 months, I'm aware that 3 days is sort of like the standard of care these days. So 3 months was only the beginning of the treatment. We'd take the patient off medicine for 3 months and see how they did. But in the time when Denise was there as the director of nursing earlier, patients were not, there weren't any medicines. So the effort had to be made to work with the patients without the medications. And the staff had come up with working together with nursing staff and the social worker and various cadre of the hospital methods of trying to get along with patients without medications. And one of the things that used to be used was the cold wet sheet pack for agitated patients. And that was phased out, but was pretty effective. And the patients in retrospect, I think, felt that they were calmed by it. It was helpful. Cold wet sheet pack. What cold wet sheet pack was the patient would be put in a little gown so they wouldn't get all wet from this, and then they were wrapped up in sheets which were from an ice chest. And it sounds cold, but you soon warm up in that because your body temperature heats it all up. So then it's sort of like a kind of hydrotherapy. You can probably get this still at spas. But you end up feeling calm. And I don't think it's, in prospect you say, oh, I'm not sure if I want that. But it has a calming effect. It also sounds kind of barbaric, and the hospital began to get harassed by the press, and we ended up having to get rid of the pull sheet. But by that time we had medications, which have a different effect. Say anything about what sheet pack besides that?
Well, it was very interesting. What could I say? There was a physiologic reason. The cold contracts I used to teach the nurses, because no one knew how to do this, the blood vessels on the surface, and that shunts the blood into the organs, interior organs, and that's what is the calming effect. Yeah. As Chris says, they probably do this at spas. You don't stay cold. But it is cold to begin with. Yeah.
Interesting. Did you have to physically restrain people to do it?
Yes.
Sometimes. Some people like it.
Did you have orderlies there that would do the physical restraints? How would that work? I'm just kind of curious.
Yeah. The strength of the hospital at the time that I arrived in before was the staff. There was lots of staff. And just as one example that I knew about more intimately, there were 30 doctors, 30 MDs, and 100 patients. So you had a good doctor-patient ratio. It also was one of the reasons why the salaries had to go up. But getting to the salary issue again, if you were a doctor there, you got this small salary from them. But then you also could use your office for private practice, and you were encouraged to do so. So thinking back to me, coming in with one patient being assigned to me, I could have had a bunch of patients. I didn't at that time because I was new, but I could have had lots of other patients. And it got to be kind of a problem where when you had a patient who got better enough to leave, then you were still seeing them, and after a little while you would end up pretty full in terms of what you could do. Soon enough, I got 6 patients. So 6 patients was the load, so that's 24 hours a week of work. And the hospital got its money's worth out of you because you were busy the other time in other things. There were conferences that you went to. Your patient would be presented at an intake conference, which happened about a month after they arrived. And at the intake conference, there would be the head of the hospital, the medical director, the clinical director, the director of psychotherapy, the head of the unit, the patient's therapist, the social worker who had taken the family history, the psychologist who had done a Rorschach and a bunch of psychological testing. And everybody would come in and talk about the patient. So that would be, and also other staff members could come if they wanted to hear what was going on with that patient, which we mostly all did because we were interested in everybody that was there. You could get to know everybody. You think of your high school class, I'm not sure how many people were in it, but 100 patients, you get to know them over time pretty well, and they're not moving in and out. They're there for 3 to 5 years. So they'd be around for a while, and you got to know. So this meeting would be one in which everybody would try to come up with a plan, the diagnostic sense of what was going on with the patient, and a plan for how to treat them. And then annually, that patient would be reviewed in another bigger conference where all these same people would be assembled again. And the issue was, well, so what had happened in the last few months and how things going with this plan? Yes?
How was the patient involved in the treatment in terms of that large consultation, the annual one?
They weren't there. That's what you mean. But the patient was involved in the treatment in the sense that their therapist was there. If you're the therapist for a patient that you see 4 times a week, your patient is there in that And also the administrative psychiatrist had been working with the patient the whole time, and the head nurse on the unit, and those people, they knew what was going on with the patient. If the patient had objections to the way the treatment was going, pretty much everybody knew it.
Were there community meetings then that were regular for the, I guess I'm thinking about the life on the unit, and how did it get addressed?
Yes. Do you remember the book called The Mental Hospital by Stanton Schwartz? Have you read that one? That's, Schwartz is Mari Schwartz, which was Breakfast with Mari. That was a book written by a sportscaster who...
Yeah.
Tuesday
with
Tuesdays with Mari.
Morris.
Tuesdays.
Oh.
That's Mari Schwartz. Mari Schwartz was at Brandeis, and Stanton was in the Harvard Systems Center. And they came down and studied the lodge. And they did a book called The Mental Hospital by Stanton Schwartz. And in that, they showed that disagreements among the staff, which were not spoken about, led to symptoms in the patients. So you have a patient with a urinary tract infection, and you could trace that to the staff disagreements which weren't being aired. And if the staff could air their disagreements, the patient would improve. So I forget the question was what happened on the unit. Oh yeah, so informed by that book, we knew how important the life on the unit was in terms of the dynamics of the unit. So we had unit meetings, which maybe twice a week, I think, where the psychiatrist and the nursing staff would meet with all the patients. And that was another place where you would hear a fair amount about patient complaints, because they would be complaining about stuff. And the units would take the patients to dinner, or they would at holiday times we would get everybody together and put them in a van and take them out to dinner. And we used to go to the beach. Chestnut Lodge is located in Rockville, Maryland, which is about an hour and a half from from the Chesapeake Bay, maybe 4-hour drive, maybe 3 or 4 hour drive to the beach. So we used to take them to the beach and rent a beach house at Ocean City, Maryland, and the whole unit would be at the beach for a week. And the nursing staff would come, and the administrative psychiatrist would drop in every now and then, and they would live there. And that was a really nice time for everybody. The whistle was blown on that by insurance companies, which would say, well, if you have your patient at the beach, I guess they're not that sick, maybe they don't need to be at the hospital. But that wasn't true. It was just nice. And I remember sitting in the little beach chair at the beach as the administrative psychiatrist was, and talking with a patient about his boyhood in Chad. He'd grown up in Africa, and he never said anything on the unit at all. But at the beach, he was able to. So again, I can't tell you what. I wouldn't say, everybody should take their patients to the beach. But there was something about the atmosphere that lightened up when you were off the unit, and if it was possible to do it, it was great. So, does that answer the question about what was going on?
Well, I think I was interested, thinking of Maxwell Jones' therapeutic community.
Yes.
And sort of how it worked there. I think you've answered that, to make it as real as you can, and the meetings then would be a place for things to get talked about, thought about.
Yeah, I keep thinking about the trips for some reason rather than about the meetings. But I remember one time we went to a lake. One of the nursing staff had a sister who owned a house on the lake. So we all went to the lake. And on that day, we had decided we would go swimming and canoeing. So we were swimming, and the activities therapist and I swam across the lake. And then there was a guy who was had been in seclusion. And when we get to the seclusion in a minute, he'd been in seclusion for about half a year. And he was out now, and he swam across the lake. But he got about halfway across and then ended up not being able to go any further. So the activities therapist and I swam back out to get him, and we kind of pushed him across to the closer side, which was now all the way across. And then I swam back and got a canoe with another staff member. And we came across with the canoe. And at the side of the lake where we were going, the staff member stood up in the canoe and fell out and tipped the canoe over. So it turned out he couldn't swim. And I'm bringing all this up just to show the complexities of running the unit. I had no idea this guy couldn't swim. I would never put him in the canoe to go across with me if he couldn't swim. So I said to him, "Oh, stand up," because we were in about 3 feet of water. And he stood up, and it was all successful. But I mean, I guess the point of my story is that if I were closely allied in my mind with rules and regulations, we would never have been out there.
Yeah.
I think there was something salutary about it, even though we were lucky in a way that it worked out. But getting back to the seclusion room, which is part of the unit situation, there was a seclusion room on every unit. And the seclusion rooms were always full, which it was always somebody else, somebody different. And it reminds me of the idea of the people having keys to the unit, the staff having keys. I think one of the things that Cyril said about that was that it really was helpful to the staff to have a key because it helped them to differentiate themselves from the patients. They then knew they were the same ones. Because if you had the key, you knew you were all right. And the seclusion room operated somewhat in the same way. I think there was always somebody in the group dynamic who needed to be secluded, which is a strange and interesting phenomenon. If we didn't have a seclusion room, would we really have had a patient who was in it? Maybe not. If we didn't have keys, would we really have had to have a locked unit? Maybe not. So these kind of things remind me a little bit of the therapeutic community issues.
Well, and I'm remembering as you talk about getting hit in the jaw and the keys being taken from me and the patient, running into the community.
Chris, didn't somebody, wasn't there the story, somebody stuffed the keyhole with feces?
Oh, that was my patient who was in the cold blood sheet pack because he was too agitated to see me and would have been hitting me. So they put him in cold blood sheet pack, but I would still went to see him. So I went in to see him, and he had smeared feces all around the room, and he was in the pack. And there was a fly buzzing around, which would land on the feces and then land on me. I was very uncomfortable, and he spent the entire time spitting at me, which was also upsetting. But I was even more upset when I went to leave the room, and I found my key embedded in the feces of the keyhole. So he was going to get through to me one way or the other.
Yeah.
Listen, you have to tell the story, since we're on the topic of poop. The question, remember in the small group, what should I do? The patient has smeared the door with feces, and who was it? Was it Powell who said, what side of the, don't you remember this? What side of the door is it?
That's interesting.
Remember that?
No, you tell the story.
Well, it's just that they said someone came to the director of psychotherapy wanting this to be taken care of. There's poop on the door. Please send somebody to get it off. And Powell said, "What side of door is poop on? If it's on inside, it's your problem."
Well, it's really interesting from a communication perspective. Like I'm thinking of when you went to the door, was he trying to keep you in, or was he trying to keep you out, or was it something about, you know?
And also, was he just trying to have me remember him? Because when I got out with my key with feces all over it, I was gonna have to put that in my pocket, you know, so I didn't right away put it in the pocket, but that, I mean, it was gonna be staying with me.
Yeah. Yeah.
So I think that's a way of not having it leave.
It makes me think of this idea of rules and regulations, and one of the things I am impressed when I hear stories about there is I think that sometimes rules and regulations can be about a foreclosure in thinking about experience. It's about not thinking about it, and rather than hopefully the goal of working with patients is to bring some mind to it rather than shutting the mind down. And it feels like you guys, the lodge did a really good job of trying to keep that space to be able to think about it without just going to, you know, the rules and regulations.
I think one of the features you're dealing with me in this setting is that and Denise is better than me at this too, that I tend to go into the particulars and not into these general. You should be discussing because I'm going to be talking about these stories and of course they should be wrapped with some kind of discussion like what you just made. It's obviously absolutely the case. This is the whole reason. And here I am just telling you the vignette. You know, but that wraps it up nicely. That's actually the idea. Yes.
Chris, do you remember how you felt when you got your key and you saw the feces?
Yeah, I felt bad. I mean, I also was upset by having the flies land on me and also by being spat at the entire session. And I went to supervision with the then director of research, who was my supervisor at that time. And he said, you should tell the patient that that's a hell of a way to treat me. So I went back the next day and I said to the patient, you know, that was a hell of a way to treat me. And actually it helped to make me stop doing it. So, well, blinding glimpse of the obvious, right? I mean, you would think that I would have thought of that, but I was upset by it. The whole situation had upset me. And when after a month or two of that, the director of therapy, Dr. Powell, said, I think we ought to, I think that the transference is too intense for this person. I think we should use medication. Because that was his way of thinking about whether medication should be brought in, was whether the patient could handle the transference, meaning handle the relationship with the doctor. And so we did use medication and shifted, although not too remarkably. Medication doesn't cure schizophrenic patients, really. It helps them a lot in the sense that they're more manageable, but it doesn't cure them. But he stopped doing it.
Christine, you mind?
Oh,
Well, I was just going to say one thing, if you don't mind. You know, I kind of disagree with you about the importance of the theories. I think that the experience of the individuals who's very sick like this, it's so primitive that one tends to reach for theories defensively. But what you're talking about is the real life that we all live with those patients. It was very moving. Yeah. In a way, you don't need a theory. What's that get you?
Well, the theories made you more comfortable while you were sitting there.
You touched on this just kind of obliquely, but I do wonder if you could say something about the impact on your and your close colleagues' minds of being with such very disturbed patients, especially at the beginning of your professional life.
That's an important
So,
point.
I'm glad that you asked that question. I was going to say something about the way the lodge took care of us. The lodge took care of us by giving us money to go to psychoanalytic training. And it also made it mandatory that we go to a small group twice a week. Small group was organized by the director, Dexter Bullard Jr., and he would, in some kind of magic way, decide who would be compatible small groups. And of the 30 of us, we would meet in maybe 5 small groups. And they were led by the director of psychotherapy or the clinical director or director of admissions. In other words, the senior cadre of the hospital would lead these small groups. And the small groups met twice a week in an hour, and they had no agenda. So they weren't tea groups. They had no agenda to help us in any way. But they were very helpful, and I don't know if I would come up with a theory like about metabolizing projections. So we would come in there and talk about what, whatever it was probably something that had just been put into us by the patient. So that was the aim, I think, for dealing with it. But it wasn't totally successful. The staff would, every now and then, the staff member would go off the deep end and either have to leave or, I remember one had fallen in love with a patient and wrote back from Europe where they had gone, well, why discuss the edible when you can live it? And the postcard. So it wasn't always totally successful. I mean, I think that the forces that you're describing did affect people a lot. Another way it affected them, I can only give, again, a vignette. Sorry about that, that's why I think I had been on jury duty, and you have to walk, when you're in Rockville, in jury duty, you have to walk downtown to the courthouse. So I had been down at the courthouse, but I had time for lunch, and I came back to the lodge to have lunch. Because lunch was actually pretty good there, so I came back there to have lunch, and I came in on a meeting of the doctors who were sitting around discussing something, and I thought, this is crazy, because I'd just been in the real world, and now it seemed crazy to me what they were doing. But, of course, the next day when I was there, I was part of it, the same craziness. But to an outsider, it just seemed so totally nutty, what they were obsessed with and worried about coming in to talk about. I can't remember what it was, but...
Would you be comfortable taking a break?
Sure.
Does that work for everyone? Yeah.
I brought in, in order to keep the meeting just organized, I brought in a sheet of paper with things on it to say, but I really don't quite know where I am in the sheet. I'll say something about the treatment of the patients. And again, I'm very happy to be interrupted if you want to talk to me about any questions. Tommy Thompson was one of the staff members. I know everybody's heard about Cyril, but nobody has heard about Tommy Thompson. Tommy was a senior staff member who was in the U.S. Navy at one point and was responsible for trying to figure out what medicine could be given to people rather than torturing them in order to get them to tell the truth. And he also was, I don't know what he came up with, maybe LSD. And the other thing he did was to interview people who were going to be assigned to Antarctica, to this weather station there, to see if they would be compatible with each other. So he was into that. But what I remember asking him, well, what should I read in order to become better at doing this work? And he said, well, I recommend 3 books. Life on the Mississippi by Mark Twain. Is Sex Necessary by Thurber and Blake. And Letters from the Earth. Letters from the Earth also by Mark Twain. And I read them, and I have to say I kind of agree with him. You know, in Life on the Mississippi, you're learning riverboat captain, how to be a riverboat captain, and there's always shifting shoals. So it's a little bit like treating the patients. You have to know where the shoals are, and you have to be careful. And in Letters from the Earth, the devil is, the concept there is the devil is writing back to God about having been sent down to the earth. And now he's reporting on what he finds, and it's crazy. The place is nuts, he says. You wouldn't believe it, the stuff that goes on. They have 10 commandments. And they're supposed to apply equally to people in equal ages. This is not even the one about thou shalt not commit adultery, if that's what I mean. You know, it's supposed to apply to a 10-year-old. It's pretty easy for them. And then, you know, by the time they're 30, it gets to be harder. 40 and 50, it's really, really difficult. By 70, thank God, it's a lot easier. So that is kind of a sad, the superego. And then Is Sex Necessary? It has some wonderful sections in it, which I recommend highly. Thurber and White is great. So, but Tommy had a way of dealing with patients, which I thought also was interesting. Nobody understood how come he was so successful with his patients, and they would ask him, "How come you do so well?" He said, "Well, I asked the history." So what he would do would be to sit with the patient, and he had in those days the phone book had a perpetual calendar in it, and you could look up what day if they were born on September 3rd in 1950, you could look up and see what day of the week that was, and he would get interested with the patient on whether if it was a Tuesday, what your mom must have been doing on Monday night. Now, that was the kind of detail of the history that he was interested in, and he would bear right down into it, and then he wouldn't take that they didn't have anything to say for an answer. If they said, well, they didn't have anything to say, he would say, I'm sure that you're thinking of something, and wait for them to talk. So, but anyway, basically it was the history taking he felt that was useful, successful. And I guess, again, Colin might say, well, that's because it shows a level of interest in the patient that they haven't experienced before, and that's what's important to them. Eric Height is also a person that maybe people haven't heard of. He was another staff member, senior staff member who I had supervision with, and he was kind of an anti-Searles character. Where Searles would say to a patient, like famously the one that killed her baby, he said, well, I guess you murdered your baby. You know, that was a famous interview that he has with somebody, it's in one of his books, and I've forgotten which one, but you remember, people who've read that book, there's an interview with a woman who's killed her baby. And he goes into the session with her and he says, I understand you killed your baby. She said, well, why would you say that? Why would you use the word kill? He said, well, that's what you did, isn't it? You murdered the baby, isn't that right? So he would be pointing out the aggression in the patient and not be shy of it. And that's one of the things that made his intervention successful, is he didn't shy away from aggression. But Eric Height was of the opinion that you should be thinking of the libidinal side of things more. And so when a patient came early to your session, he would say, and knocked on the door and you were still seeing your other patient, he would not be like Searles maybe might say, what the hell are you doing outside my door knocking? I'm seeing somebody else, go away. Not Eric Height. Eric Height would say, oh, you're so eager to see me, how nice that you're here early. Unfortunately, it's early and you have to wait a few minutes because I'm still seeing somebody else. But he would embrace the positive. And that to me was an interesting other view. I remember his being in what he called a hatching silence with the patients. He had been himself trained by Maynard Voss, who was an existential analyst, and he believed in hatching. The patient would hatch forth. And so if you sat quietly with the patient, even if the patient wasn't speaking, he didn't, like Tommy Thompson, ask the patient what was on his mind. He would just sit there. And that was his version of a hatching silence. And to me, it seemed useful. More story about him. Oh, he used to be at the Recollections, I think is the name of the hospital in Switzerland. He had been conscripted as a soldier in the German army during the Second World War, and he spent his entire rest of his life absolving himself of guilt about that. But one thing that he did was to work at the Recollections, and there he said, it's similar to the business of taking patients out to dinner. The patients would get dressed up in black tie to come to the dinners at the Recollections, even if they were very secluded and very regressed in seclusion room. They would get dressed up in black tie. And a patient who was catatonic, he said they would take out and throw into the lake, and then they would swim. So that was the improving treatment. Wow. More about your But I think Eric Kite was, again, it sort of surprised me. I hadn't expected to find these characters. John Cameron, who was the director of research before, Denise wants me to talk about Tom McGlashan and his work as director of research, but John Cameron was a Scot, and I used to ask him, how do you manage to be so unperturbed in the face of all these things that patients do? And he said, well, when he was in the army, he was captured by the Italians in the desert in North Africa, and he was taken out every day to be shot. And they would never shoot them, but he said it was so horrible that nothing else bothers him now. So that's the guy that told me I should tell my patient that if you put poop in the keyhole, to tell him it was a nasty way to treat me. So Denise wanted me to say something about Tom McGlashan, who ran a research project, follow-up study of all the patients at the hospital who've been treated over the years. And that showed in the end that only maybe 1 out of every 3 schizophrenic patients got it in any way better. But a lot of the borderline patients got better. And so in a way you could say that this treatment program was actually better for borderlines. And it's not a big secret why it would be. The schizophrenic patients have, in a way, a lot of ego deficits, and the analytic treatment is not going to necessarily directly address those kind of deficits. But the borderlines didn't have any of those same ego deficits. Really, they were fine in that way. They just had all kinds of problems with these approaches of close interpersonal work. Actually, is a lot of helpful. Yeah. We got better at the lodge. The McGlashan study didn't address how we changed, because it stopped before we changed. But we changed in the sense that we began to address more of the deficit states. And I'll just give one vignette about that. We had a social skills group on the unit. That's addressing a deficit state, we thought. But we had a visitor from Sweden who was a psychoanalyst, and they came to observe what we were doing. And the guy turned to me afterwards and he said, I don't know why you're doing this. He says, it's not that they don't know how to say hello to each other. They know how to do that. It's their aggression that gets in the way. I mean, you're supposed to be a psychoanalytic hospital and you're running a social skills group where they say hello to each other? That doesn't make any sense at all. It's the aggression that's getting in the way. So I thought that was an interesting idea. And later I took a patient who was going to go and buy something at the sundries store. There was a little store that sold, candy bars and stuff. And I took her there, and the store was being run by another patient who had that as a job on the campus. And so she, using her social skills that she gained in the social skills group, she says hello to the guy behind the counter. And the guy didn't say anything. And after a few minutes, she turned to me and she says, dumb fuck won't say nothing. So it seemed like we were seeing a confluence of. But we did make a big effort to try to work on the deficit side of things, get people jobs. There was a vocational person that would come in, and I remember a patient who was very regressive, ended up working in a local print shop and did a great job for them. But they would do things like show up late, and the lady that worked with them would do things like come in and tell the employer, please don't worry about that so much. The important thing is something else that they were doing. So she ran interference for them, and it really helped them a lot to keep the jobs. Yeah.
Were they working while they were a patient there?
Yes.
Oh, so they would leave the campus, go work, and
Yeah. And of course, we later had step-down houses where they would live off campus, and those were staffed a little bit more rudimentarily, so that sometimes there were problems like the person would need more staff input, but oftentimes they were kind of trained up. So I remember one woman who was in one of these outpatient houses who needed extra help, and she would show up at the unit and say, I need a pack, in the cold sheet pack. And then they would put her in the pack, even though she wasn't actually an inpatient at that time, and the paperwork wasn't right for her being in the pack, but they knew her, so we just stick her in the pack. So that, that worked in some cases like that. And there was a certain fluidity between being still a patient and being out working in the community. And out working was like John Romano telling me, one of the things you should do for these patients is get them work, because it builds their self-esteem.
Chris, don't you think you should say something about how the longevity of the relationship between the patient and the therapist was so important?
Well, Sherry asked me if I would say something about the treatment of a patient. And a couple of patients came to mind that I've treated for a long time. One that I'm going to be talking about just briefly at the ethics,
The folk.
Ethics Conference, who had been considered to be a very dangerous patient. I know I'm going to say something about him at the book, but he had tried to drown himself in Lake Michigan in order to prevent bad things from happening to other people. Kind of a paranoid idea, but it was dangerous for him. And he was admitted to the lodge and would occasionally become very wrapped up in his paranoid fantasies. One time there was a guy named Lenny Bias, who was a basketball player from Maryland, who died of a cocaine overdose, and my patient thought that he killed Lenny Bias, and he began to try to hurt himself again based on that. And we had a consultant, Arthur Hyatt Williams, who was a famous guy from England who worked with disturbed patients, and he told us that this was the most dangerous person he'd ever met, and that we should definitely confront him. And the guy would oftentimes barge into the kitchen on the unit and make a sandwich at a time when he wasn't supposed to. And these were periods when Arthur Hyatt Williams would say, you should really be confronting him. And in the treatment, interpersonal treatment, I should be confronting him. So I never did, because I'm a mouse. I found. And he's been fine. He's never hurt anybody, and he hasn't really, and I've seen it, I still see him, although it's long distance now.
Wow.
He's been good. So, and he and I have wide-ranging discussions about many things that that we both are happy to speak to each other.
So how long have you been seeing him?
At least 30 years.
How frequently?
I see him now once a week. It had been 4 times a week to begin with, which is an interesting, I don't know what you all think about this. My own experience is that if you see somebody 4 times a week for a few years, you can probably reduce the frequency of sessions with these more severely ill patients to less and still be pretty effective, because you have a history together and you pick up right where you left off. In fact, some people, if you don't see them for 3 years and you've seen them in 4 times a week treatment and they come back, they lie down on the couch and begin right where they left off without, any, as if they didn't have any time away. Which is like Freud's talking about the unconscious, it's timeless, really doesn't. So this patient had asked if I wouldn't see him less than 4 times a week, even when he was in the hospital. And at that time, Bob Cohen was the director of psychotherapy after King Powell, and he had to go to see Bob Cohen about that. And Bob Cohen told him, "Oh, I guess we'll make an exception for you." So he saw me 3 times a week when he was in the hospital. And I don't know exactly, he would never say what his reasons were for anything he did. Not Bob Cohen I'm speaking about, but the patient. So if you asked him, well, how come you want to see me less than 4 times a week? He would never say. He would say, let's talk about DNA. We were talking about DNA yesterday. Let's discuss DNA. And we go back to talking about DNA, which he was an expert on because he was a scientist. And so we were talking about DNA. And I think Arthur Hyatt Williams would have said, no, you've got to ask him, you didn't answer my question, really get him to confront his own aggression and hostility.
I guess it's in his DNA.
Huh?
I guess it's in his DNA.
Carl Jaspers, there's a quote from Carl Jaspers that your doctor is your fate. And in that sense, I was his doctor, and it was his fate that I never did confront him about his aggression. And I don't know what would have happened if I was a different person. I think the idea that your doctor is your fate is a big idea, which deserves thought, because when you go to see an analyst, it may be the last analyst you would ever see. Some people get more than one analysis, but when you have one and that is it, in a way, the analyst's shortcomings will never be something which you'll be able to get beyond. So my shortcoming, which is I didn't confront his aggression, is going to be a problem for him. I mean, his family or him could have asked for a different treatment situation, but they never did.
So I had asked Chris if you would talk about a patient which she just had. And I realized there's a question I don't know how to formulate in any way that it can be answered, which is you're describing Chestnut Lodge, which is a very unusual place and has high charisma in our minds. For me, almost all associated with circles because I don't know much else. And there were only psychoanalytic therapists there, psychoanalysts. And so I think my question is, even though it was a very different place, was the actual work of psychoanalysis really different than somebody who's never worked in a mental hospital becomes an analyst and works with somebody? And I don't know how you can answer that.
Well, I don't know if this is part of the answer to that. I was going to speak about what kind of psychoanalytic hospital it is. It's not, you don't see the patients 4 times a week on the couch because they're not capable of doing that. So you see them, I mean, if one were capable of it, you might, but what did it mean that it was psychoanalytic? What that meant was that we had all psychoanalysts thinking about the patients, and we would think together about the patients. It was kind of a, you know that thing in Who Wants to Be a Millionaire where you use the audience line? So, you know, you could get the wisdom of the group to focus on what was going on with the patient. And when I became director of psychotherapy and used to run the Wednesday conferences, which were the times when we would talk about what was going on with the patient after each year, the team, which included the therapist, and the therapist would ask me, well, what do you want me to talk about? And I would say, well, why don't you say, what do you think the problem is that you're working on with the patient? Which, of course, they never knew, but I would say that. Why don't you think, what is the problem that you're working on with the patient? And then tell us what you tried to do about that. And then tell us what happened when you tried to do that. And if you do those 3 things, that'll make an interesting conference. And to me, that's kind of the essence of the psychoanalytic enterprise, is to try to figure that out. I mean, I think that you can see it on different levels. Maybe the analysts have a way of understanding it partly from unconscious forces, partly from that side, from the offenses, thinking about the various agencies of the mind, what the ego is doing, and so forth. But essentially the issue is, what do you think is the matter here? And what are you trying to do to fix it? And what's happened with that? So if we tried to look at that in these Wednesday conferences, I thought we would be accomplishing a lot. And of course, they would get hung up on the first question. Nobody has the vaguest idea what the problem is. I mean, nobody can address that. But if they could think about it a little bit, it would be a help. And so, in the sense that the treatments were backgrounded, so to speak, by an interest on the part of the staff in psychoanalytic developmental theory and in interpersonal theories and in the drive and defense models or the object relational models of treatment that we had all learned about in the institutes. In that sense, it was psychoanalytic, not in the sense that we applied psychoanalytic technique in a narrow idea of patients.
How did Klein and Bion and Meltzer come into play?
They came into play because we would learn about them at the institute, and we would come back and we'd say things like, "Well, what do you think about this patient in terms of ideas that Mel and Klein had?" And but often, of course, the way I think about it would be in the term like vignettes. Like a patient would come in and you would have been late because you had the daycare problem and you had to sort out that before you came in. So you missed the first 5 minutes of the session. So the question is whether you would say anything like that to the patient. You would say, well, I'm sorry I was late because I was taking my kid to daycare and there was a problem with that. Or would you just wait for the patient to get mad at you and then deal with the anger that the patient had? And I don't know where I read it, and maybe it's even apocryphal, but I heard that Melanie Klein had a problem like that with daycare. And she thought that it would be better to tell the patient, otherwise the patient would be imagining all sorts of horrible things. So she actually told him, no, actually I was at daycare, so that's why I'm late. So you don't have to worry that it was something about you that made me late, it was my problem. So I got no idea whether that's actually a story from Klein, but that's the kind of thing that would, and of course there's no one right answer to it, but we would discuss it. Doesn't that mean something different? I don't know whether it happens in every psychiatric hospital, but the levels of discussion were closely around issues like that. I remember one time as the administrative psychiatrist, the question came to me was whether the patient could go home on a vacation to see their mom and dad. And it was coincidental at the time coincided with the vacation of the therapist. And the therapist had come in to argue, and we had to sort this out with the various cadre of the hospital, the higher cadre, higher than us. I was just the administrator, and the other person was just the therapist. And the therapist, felt this was the wrong time to let the patient go home for a home visit, because the transference would be that she would want to go to see the parents instead of to see the doctor, and that she should be kind of steeped in the problem of not having the doctor there rather than being allowed to act out by going home to the parents. And I argued that this was a good time for the patient to go home and see their parents because the therapist wasn't there and they weren't going to be doing anything else while they were at the hospital. Why didn't they go home? So that was discussed. And
you know, what you were saying about a psychoanalytic developmental model, I think it addresses Sherry's observation, because you could think of it this way. If you look at a mother who's just had an infant, or even before, during pregnancy, mother and infant are step by step creating a relationship in small and smallest increments. And I think that comes very close to what you're constructing with especially a patient who's more severely impaired. You are coming to know one another and how these two people do things together, all kinds of things, you know. So I think it's like, I was thinking about Henley. When you asked Henley, or somebody asked Henley, what are you using your couch for? What's the punchline on that?
So this just reminded me of a story. That was a guy, I didn't mention this guy, Henlick, who was a guy who was famous for getting the patient's number. That's the way he talked about it. He would get the patient's number. After the first couple of months of treating them, he had their number.
What's that mean? Getting
Yeah.
Good question.
Figure them out.
Oh, okay.
Huh?
Oh.
We'll figure them out.
Figure them
Oh,
out.
okay. It's like you figured them out. Okay.
Yeah, sort of.
So in his later years, he would stand around outside the building that he worked in because he had severe diabetes and had an amputation. He couldn't get around much. He would stand outside, and as we walked past, he would say to us, well, what's the gossip? Because he was always interested in what the gossip was, as if he thought that the gossip really would hold the essence of what was going on in the world. And we would tell him the gossip. But the question that was asked him, what use did he make of his couch? He would say, well, I file magazines on it.
Did Chestnut Lodge, when you were there, have voluntary and involuntary patients, or And were they treated any differently, or did you notice anything different when they were coming and wanted to be there, wanting treatment versus there and weren't wanting treatment? Yeah.
Well, I think, first of all, we did have both types. I think in general, the people who want to be there have a leg up in terms of how they're going to do. And it's hard for the people that don't want to be there because it's a hellish place to be and stuck in a mental hospital. And even if it's a nice one, it's still bad. And you're there against your will. It's not a good situation. I was talking in the break about a patient that I have currently whose daughter is an eating disorder, and she's at Overlake. And the treatment, apparently, I heard from the patient, I heard that the treatment involved keeping the daughter kind of locked up in the eating disorder unit and making sure she gained some weight. And actually that had a salutary effect on the daughter in the sense that now she's heavier, not about to die from eating disorder, and now she can engage in the treatment. And in some ways that happened at the lodge too with the involuntary patients once they got there and got involved in the involuntary treatment. And the treatment actually helped them to get a little bit better. Then they were able to make use of it. Mm-hmm. So I think it wasn't too big of a distinction. You just had to weather a little bit more time when they were getting ramped up, so to speak. Yes.
What did it mean to you when Chestnut Lodge was no more, or your process of leaving? Because it sounded like you were there until it ended.
Yeah, I'm glad you asked that. I mean, those of us who were there for a long time felt a lot of grief about the end of the hospital. Because we thought it was it's made a serious effort to address the problems of these tragically afflicted patients in a way that isn't being done in very many places. I think it is being done some places, like Austin Riggs, for example. But only they're a little limited because they can't lock people up in case they need to be treated against their will, which is an important part of the treatment. When somebody is psychotic, they don't always know they need it. So we felt grief about it. I think we'd already been grieving. It's a little bit like having a spouse who has some kind of serious illness which makes them debilitated for the last 10 years of their life. You've already lost that spouse 10 years ago. And so we had already lost the lodge as it had been because of these forces that I was trying to describe about the insurance company saying, well, you know, patient can't be that sick if you have them at the beach. So we hadn't been able to do that. We used to have dogs on the unit too, and the dogs had to be scrapped because patients would be allergic, and then there would be a question about allergy. You know, come on. But that was a serious issue. We had to take it seriously. So we began to kind of ratchet down on what we were able to do in a more free-wheeling way, which I think was, we grieved that also. And we were mourning that loss. The owner of the hospital, which was Dexter Bullard Sr., evolved to Dexter Bullard Jr., and then he died prematurely of lung cancer. And the hospital had to figure out a new ownership, a new person to run it. And they got Wayne Fenton, who had been the director of research after Tom McGlashan, to run it, and he did okay with it, but there were a lot of efforts that he had to make in order to fit in with the cost problems. That meant that we ratcheted down on what we were offering. So we were already ratcheting back on what we were offering because of that. We had a visitor, Joseph Sandler, who was he came and said that he thought it was a great hospital, but he felt that there would be no way that this could exist from a monetary point of view unless it were a research hospital and got research funding. And we did have research efforts, and that was funded, but it wasn't enough to fund the whole hospital.
I'm interested in knowing about ECT and whether it was used in the facility, as there's a resurgence of it, it seems, locally. And having assisted back in the 70s when I was in the military, and remembering the patient getting up off the table and me walking him back to his bed and him saying, I hate myself.
Well, every now and then you run up
I
against...
hate myself.
You get a patient who needs ECT. So a nightmarish thing for any psychoanalyst is that you have a patient on the couch, for example, who is complaining of blurry vision, and you keep interpreting to them, that something about their dynamics. And it turns out what they would benefit from is eyeglasses. So it's a problem for the analyst. And at a psychoanalytic hospital, if you have a patient who has the kind of depression, say, which would benefit from ECT, and you keep trying to talk to them, or maybe even eating disorders as an example. We had a number of eating disorder patients at the hospital, and one time I had a consultant from Hopkins come who told us that there was no way that we could talk to a patient who had anorexia. All they would talk about the entire time was food. The only thing you could do would be to refeed them. That was his term. And at the Hopkins unit, they would sit them down, they would sit with them and feed them until they got enough weight on them that they could talk again. Because up to that moment, they were unable to do anything except just talk about food or resist it or something. And with the depressed patient, there's a classical kind of depression, of course, which everybody knows about, which is for which ECT is a good treatment, and that is the agitated, depressed, psychotic depressed patient. So you have a person like that at the lodge, and most of us in 1978, all of the 30 doctors were MDs, so they all knew that, and they'd all had experiences like you're talking about in their training. And they could pretty much recognize when a person needed ECT, so they would send them to another hospital to get it. We didn't do ECT, but we were sending them.
What does that look like more specifically?
The agitated depression?
Yeah.
Well, let's say that you run a major corporation, and you come into the office and you begin to walk up and down the hallway, wringing your hands and saying to the staff, like secretaries and things, I'm totally out of money. My wife is in the toilet, and there's absolutely no reason for it. It's just delusional. And they're wringing their hands and they're looking and they become suicidal. So that's an agitated depression. Maybe not give a full picture, but it kind of gives you a flavor for it. And I remember as a resident being lectured by, there was a visiting professor from McGill, which is a university in Canada, who came and said, if I ever get a depression, he says, I hope that people will give me ECT because I'll be better from it in 2 weeks and be able to work again. And it's a great treatment for that, for a certain number of things, like agitated depression, they respond to it. So it's worth sending the patient for it. And we used to do it. The question comes as to whether the patients who have schizophrenia ought to be on medications, and that was hotly debated at the lodge for many years. And these Wednesday conferences would end up in like Republicans and Democrats. I mean, there was hot feeling about this. The people who were the old hands who knew that the relationship was everything did not want to muddy the waters by giving the medicine. And the newer hands were thinking, well, I don't know, I saw that in residency. I saw the patient taking a little Thorazine, and that didn't mean they couldn't talk to me. So there was, I think, a lot of discussion around that issue. It sort of reminds me of the ECT question, because you would have one treatment modality, which is a talk therapy, and the other treatment modality, which is psychopharm. And are you going to use both, or just rely on one? And if you, in the psychopharm, essentially what you're saying, if you say to the patient, I think it would be good for you to be on a low Risperdal, what you're saying is, I don't think that the relationship between you and me is going to be enough to fix this. I don't think there's any way that the two of us working all by ourselves are going to do it. So you're essentially, it's a vote of no confidence to the relationship. So that is a problem for people who are interested in solving the issues through relationship. And yet, there's a lot of pressure from everybody, the insurance companies and the families and everybody, to put a person on the medicines that you're comfortable.
Well, the current state of things is that there are no relationships in psychiatric hospitals.
Yeah.
But they can't exist because there's only 3 days for them.
You're talking. I mean, I was just struck by you having 6 patients. Some doctors at my hospital have 15, sometimes 30.
And they maybe see him once a week for 15 minutes, it seems like, though.
I think they see him like 5 minutes a day, maybe. Sometimes I don't think they see him.
But the situation that I'm describing
Maybe
in the
not 5
lodge
minutes.
is unfortunately is truly unusual. I think it's very unusual. So in a way, you might say, well, what is the relevance even of discussing it? That it's totally impractical. Nobody can do it. And even somebody like Sandler said, this is not going to fly unless you get funding from some other source. So in a way, it's a treatment model which is impossible. But in another way, it's not impossible. It just depends on how you want to define what your resources are. Let's say you decided on B-1 bombers as a priority. So now you're suddenly taking $3 billion off the table, which could have been used to set up a hospital like the Lodge. So I think we're making decisions like that all the time. We just, in a public health kind of way, that these decisions aren't. And would you say nobody knows about the Lodge and how successful it could be? I think there you run into the problem that the guys that are sorting out public monies and where it's going to go are saying, well, what's the evidence that that worked? And there you have Tom McGlash's study, which showed that actually it didn't work. But Tom McGlash's study didn't study it as it became later embodied. Because he didn't study it after we got more involved in helping the deficit treatment. So you could still have a model where you're helping the deficits and also devoting a lot of attention to the impersonal. What would be the matter with that? And they do that at Austin Riggs. And they managed to make Austin Riggs fly. I don't know how they do it, but that still exists. Even Menninger's doesn't exist the way Austin Riggs does. Menninger's had to go down to, what is it, Rice or somewhere? They're down in Texas.
Yeah.
And I don't think it's the same place. I've heard from staff members that it's not the same place that it used to be. But Riggs may be still. Anyway, it's a public health issue.
Well, so I'm thinking about part of the way it was psychoanalytic was these 30 psychoanalysts who were able to really talk in depth about individual patients, which is also an ideal which we don't really have. When you're in psychoanalytic training, it's not the same because you're trying to do the right thing and you're being, monitored from on high and you might not make it through your training. And then when we graduate, we might have something like this, which is is useful but not the same. Or we might have small consult groups, which is probably the closest. But there's not a lot of big extended time ongoing group thinking about a patient.
That's a good point. And that could be, I guess that would be a step that people could take.
Yeah.
Well, I guess I had a question about, given the constraints that came over Chestnut Lodge and that are over most of our facilities today, what is required at the administrative level in order for analytically informed treatment to flourish? Because I don't think the answer is just make everybody in the hospital staff an analyst. That doesn't necessarily address the need, but what is required at the administrative level?
I'm really glad you asked that, and I'm so sorry there's not so much time to answer, and we've got to stop in a second here, but I think I was thinking about that problem a lot before I came in today, and I was thinking, it takes a village. If you ask me, since you know so much about it, why don't you start one of these places tomorrow? We need it. I would say, I don't have chops for that, because you have to have, like, for example, Dexter Bullard Sr., who brought these disparate people under one roof and tolerated all the dissension, tolerated the crazy problem of the press coming in and saying, well, you put people in cobalt sheep pack, that's barbarous. Tolerated all the swirling objections of the insurance companies and was able to stomach all that. So you need somebody at the top administrative level who can take the flak, and it takes a certain kind of personality, and then they have to have the vision to put it all together, and it costs a lot. So I'm afraid it's not easy to set it up. Even if you said, well, you're such an expert, I'm going to refer you to some of my more difficult patients. I say, oh, that's great, thanks so much, but I can't do that because I don't have the setup that I would need to do a good job with them. I know what that setup is, and I don't have it, so I can't see it. I mean, I would be glad to see it, but it's hard to say I would be definitely successful.
Well, looks like about time. Thank you so much.
Thank
It's
you.
been wonderful.